Our next speaker is from Washington University School of Medicine. He's actually working in the Alzheimer's Disease Research Center, but his expertise is in autoimmune encephalitis. So we're going to get set up here. Greg Day. All set.
Now that we're set up, so I'd like to also thank Dr. Schlager and the organizing team, as well as our parents committee. You'll see in a moment that I have a close affiliation with other parents committees that are involved much in the same way, in kind of an organic means to better identify these diseases and improve the care for our patients. Now, I get the pleasure of talking about autoimmune mediated encephalitis in the modern era, with a subtext of spanning history from witchcraft to what I would term neurologic wizardry. If you're a psychiatrist or a psychologist, you may take offense to neurology claiming credit for it, but neurology has a long history of claiming credit for things we don't necessarily deserve. Disclosures of interest here. So I do have research funding which comes from some private organizations, the Western Brain Institute, a Canadian organization, and upcoming from the American Academy of Neurology, as well as my relationship with parent organizations. I am one of the founders of the Anti-NMDA Receptor Encephalitis Foundation in Canada, which was an organization that came out of the drive of a parent who remains as the president of our foundation. I continue my work there, but I suspect, like most people at this table, I get no compensation for that, at least not financially. I do have an unrelated research project which is supported by an in-kind gift from Avid Radiopharmaceuticals, and I hold stock in a generic pharmaceutical company which, to my knowledge, has no interest or products in development in these diseases. The objectives for the talk today: I'm going to review the history of autoimmune-mediated encephalitis, which I've termed AIM, just for simplicity. I'm going to identify clinical and paraclinical features that are associated with AIM, trying to build off the platform that's been well established by the excellent speakers we've had so far. I will prioritize, or help you to prioritize, diagnostic investigations in patients with suspected or confirmed AIM. And finally, we'll chat briefly about the challenges in the acute and chronic management of patients with these disorders. So starting through a walk-through history, we start where much good medical history starts, in the Dark Ages. And if you're taking notes, this is a time I suggest stopping. I'm going to briefly paraphrase the history, and meant to bring some levity to what is otherwise a very dark time in neurology and psychiatry. And this is a photo here, or a painting taken from around circa 1500, which depicts a relatively normal occurrence for that day. A young woman who seems to become faint with some disorder and being exorcised by a member of the religious order, and you can see a little demon flying out of her head, which connotes a successful treatment. Now, from this painting and from a brief review of the literature, I can come up with an approach that you would find valuable were you a neurologist or a practicing clinician or a barber surgeon in the 1500s. The first question, when you're approached with a patient, such as a woman acting bizarrely, that you need to ask yourself is her uterus wandering? Very important. If you can confirm by some diagnostic test, perhaps knocking or auscultating, that it is, I suggest you fix it, of which she'll probably die of a complication of such surgery, but nonetheless. If it's not, the second, and this is another very important question, is she demon-possessed? If she's not, you need to follow that up with a third question: is she a witch? Now, if she is, the treatment's quite clear: burn her. If she's not, unfortunately, you ask that third question and she's already died of a witch hunt and the general townsmen coming up in arms against her. If you conclude, though, that she is demon-possessed, you can employ a very effective treatment, which would be an exorcism in this case. Did it work? You've got to ask that important question, as we still teach our residents today. If yes, follow that up with a careful question of, is she a witch, and head down that pathway. And if it didn't work, you probably should burn her because she's still possessed and you have no other solution for that. So, leaving the Dark Ages, we're going to enter what I will term the Age of Discovery. I start my timeline in 1900, but really this is all predicated on the shoulders of other giants for their time from that. In the 1900s, late 1800s, we begin to see in the literature cases of derangement or encephalitis with accompanying respiratory infection that begin to appear. And a para-infectious etiology is hypothesized for many of these. By 1956, we begin to describe this entity of paraneoplastic diseases. And this is really driven by the adult realm of neurology and related in medicine. But describing neurologic phenomena in patients with metastatic or neoplastic diseases where the neurologic phenomena is not directly attributable to the cancer itself. So this is termed a paraneoplastic disease. Within this subset of paraneoplastic disorders, in the same year, we begin to see case reports of patients with mental disorders described in association with lung cancer. So we begin to understand that this yellow represents neurologic complications or central nervous system brain complications and encephalopathy, changes in thinking due to a cancer. By 1965, we start to see this emergence of autoantibodies being detected, and in this case, detected in brain extracts from patients with carcinoma that react against brain tissues, much like we've been hearing from Dr. Cunningham's talk. We actually have derived techniques now, very novel at the time, to study these antibodies. And although we saw much more beautiful pictures in the last talk, this is what was convincing in a journal in that day to show antibodies binding neuronal cells. And really, this is where we first see this emergence of a label that could be applied to say that these diseases represent an autoimmune-mediated cause of encephalopathy, autoimmune changes to the brain and towards thinking. And we enter this new era over the next 50 years or so, from 1965 to the present, where we begin to see an increasing number of autoantibodies described against brain targets. Specifically, one of the biggest classes of these antibodies are targeting neurons themselves. The antibodies or components within the neuron of either the nucleus or the cytoplasm. And these are termed intracellular neurons. And in our field of adult neurology, these are very commonly found antibodies in association with systemic cancers. And they may produce neurologic syndromes, including encephalomyelitis, as well as limbic encephalitis. So we have a second subset of disorders that we can think of, where a limbic encephalitis is defined as a change in personality and behavior, consciousness, seizures, and often other forms of limbic phenomena, anxiety, depression, those kinds of features. These diseases remain quite prevalent. So this is a study that is published sort of ahead of press in the journal Neurology, which prospectively surveyed 264 patients with a biopsy-confirmed small cell lung carcinoma and determined that in almost 10% of these patients there was a defined paraneoplastic neurologic disorder, most common being Lambert-Eaton myasthenic syndrome, but other causes, including limbic encephalitis, were identified here. So these diseases are common in association with cancer. As we move along in our time spectrum, though, getting around to the beginning of the year 2000, 2001, we start to see a new class of antibodies becoming better described. And these target components within the synapse of the neuron. These are synaptic intracellular antibodies, good examples of which might include amphophysin and GAD65, and the syndromes which they cause include limbic encephalitis and refractory seizures. And what's important about the detection of these antibodies is that really we begin to understand that these antibodies may be found in patients that don't have a tumor. And the literature that supports that is one of the first papers here in describing cerebellar ataxia in association with anti-GAD antibodies, and the pediatric literature really starts to ramp up here. We begin to see in cases of encephalitis associated with GAD autoantibodies in a child, and from a Toronto group where I was doing my residency at the time, we saw a number of cases that were associated with very prominent limbic encephalitis, refractory seizures, and the only measure we could identify was one of these intracellular antibodies. At around the same time is where we begin to see new antibodies described that explain old disorders. A good example of this is anti-basal ganglia antibodies. It's a description in 2002 in persistent Sydenham's chorea patients. And really, we now have an explanation in an autoimmune realm for diseases that were called many, many different things through history. So going back to being attributed to some evil humor in the 1600s, to ischemia or an embolic phenomena in the 1800s, to hysteria in that same decade or same century, and then the emergence of the idea about infection driving this and inflammation, which we're still learning about and building upon, as well as how post-infectious components play into Sydenham's chorea. But 2007 is where I become most interested, partly because I'm now beginning my medical career, at around the same time that autoantibodies targeting central nervous system NMDA glutamate receptors are described in 12 women with a very stereotyped clinical presentation that includes an ovarian teratoma, psychiatric symptoms, and progressive encephalopathy. And this is just showing the antibodies binding the complex of NR1 and NR2 that forms one of the glutamate receptors. And this is the entrance of a new subset of disorders termed cell surface synaptic receptor disorders. So the antibodies are actually targeting receptors on the neuron surface, which means that they can be treated. If you remove the antibody, the patients tend to improve, but they can also account for a wide variety of patients' symptoms, including fluctuations. And the most prominent symptoms described in this subset of disorders include psychosis, limbic encephalitis, movement disorders, autonomic instability, and sleep disorders. And because we have now an antibody that we know is causal of this, if you put the antibody in, it causes it. If you take it out, the patient gets better. We have a new subset of autoimmune disease to discuss, which is antibody-mediated encephalopathies, is what I've termed here. And why is this so exciting? Well, because it turns out to explain a lot of patients that we've been seeing before and continues to explain a lot of patients we see now. And that's evidenced by the fact over a very short period of time, a single group from reporting this in 2007 till 2013 when they published this paper described this syndrome in over 577 patients, presenting with a variety of different clinical symptoms. And that included 188 pediatric patients, so very relevant to the pediatric period. Moving through the history, we enter the Age of Enlightenment, where the question really becomes, if AIM exists, how do we begin to recognize that as clinicians, as parents, as people involved in providing healthcare resources? And why do we need to recognize it? Well, we need to recognize it because it's prevalent. So one of the retrospective studies recently published here looked at a 10-year period and found that over 230,000 adult patients were hospitalized in the United States for acute care related to encephalitis. So a population prevalence around 7.3 per 100,000 people. This is the breakdown of diagnoses, known and unknown. And if you look in the known category, importantly, 17.3% of those patients had other specified causes. Let's look a little bit further at that. So patients with other specified causes were twice as likely to be females, a phenomena that we know to be common with autoimmune disease. And this group was comprised predominantly of patients with autoimmune-mediated encephalopathy, many of them with specific antibodies, and NMDA receptor encephalitis being one of the #1 causes in that group. So these diseases are prevalent in adults. They're also prevalent in pediatric patients. Although our N here is smaller, this is a study in Australia looking at 164 patients that was just recently published as well, over a 12-year period, found that the #1 cause of encephalitis in this patient population, this is an inpatient population, was AIM, so autoimmune-mediated encephalopathies, accounting for 34% of cases, with another 8% related to what was described as post-infectious phenomena. And this is higher than our infectious causes here. We do still have a big subset of unknown patients. Our work is not finished. Why is AIM important? Well, I think we've been hearing a little bit about when these diseases present. And we see here in this figure, the autoimmune-mediated encephalopathy, or this light gray. We see that they are very relevant in the pediatric population, and they're there throughout the age spectrum, with a peak sort of mirroring some of the other talks that we've heard, around 3 to 4 years, and possibly still relevant at 8, 9, 10 years, but falling off at 10, 11, 12, et cetera. So how do we recognize these diseases? Well, we begin to think about criteria that we could employ to ask if a patient has such a disorder. And I think one thing that's important is that these AIM criteria specify that patients have a syndrome of neurologic and/or psychiatric dysfunction, which affects one or more brain systems in the neurologic and psychiatric domain. But the list to choose from reviewing these patients, from being involved in their care, from looking at the literature, is quite extensive. And I think we could add even more things to this list. So in the neurologic, we have everything from simply altered level of consciousness and seizures, all the way down to salt-wasting syndromes. And in the psychiatric, we have everything from emotional and behavioral disturbances to catatonia, hypersexuality, interesting phenomena such as that. These diseases tend to be associated with an immune response compromising brain function, and ideally we're going to have some objective marker of that. So one of the things that we consider is the CSF analysis. Leukocytosis, increased white blood cells, more than 5 per high-powered field, is seen in anywhere between 17 and 80%, depending on the criteria for entry. Increased protein is seen in as high as 80% of people, and oligoclonal bands are seen often signaling antibody synthesis in the CSF in between 32 to 60% of patients. Neuroimaging can support this. However, neuroimaging, at least at presentation, is often very normal in patients with AIM, in at least 66 to 73%. And if there are abnormalities, they may be nonspecific, not entirely helpful, such as punctate white matter changes signaled by the red arrow there. We do occasionally, though, see very definitive findings that support an inflammatory or autoimmune cause, including temporal lobe hyperintensities, which correlate very closely with symptoms of limbic encephalitis. And if we use other metrics, we have more sensitive tests like EEG, which is not specific, but does demonstrate abnormalities in up to 90% of patients with AIM at presentation. The most common abnormality being slowing. generally in a delta frequency in more severe cases, but electrographic seizures may also be seen in 20 to 60% of cases. And in rare disease, specifically in NMDA, in around 30% of those patients, we may find phenomena that are specific to that patient group, including extreme delta brush, which has been described in patients with NMDA. These diseases may be associated with an autoantibody, which brings up the need to look for this in the right patient. And the way that we look for this can be quite complicated. We do need labs that are capable of this and are willing to do this in as objective a way as possible and do a lot of it, requiring different techniques for different antibodies, maybe immunocytochemistry, immunohistochemistry, or cell-based assays. The photo here is a cell-based assay. These are human embryonic kidney cells that are forced to express an NMDA receptor and shown binding with serum or CSF from a patient. And these diseases may be associated with a tumor. The may is a particularly important word to emphasize, particularly in this audience, because the discovery of tumor is relatively rare in pediatric cases, but the risk does increase with age. And drawing again on the example of NMDA receptor encephalitis, we see that the tumor risk shown here in red increases in the age group sort of around the adolescent period of 13 to 18. And this is really related to the high prevalence of ovarian teratomas in that subset of patients. So what do we do with this information as we enter the industrial revolution? Well, testing for AIM, how do we do it? So there are some panels that are available through commercial entities. I'm showing the one that Barnes Hospital uses here in Washington because that's the most common one that we're sending nowadays, and this is the Mayo Paraneoplastic Panel. Not very valuable for the pediatric population because most of these antibodies you would recognize from earlier in the history. These are targeting intraneuronal components and are highly associated with small cell lung cancers and other neoplasms. So we have the autoantibody-mediated testing panel through Mayo, which includes a wide range of commercially available autoantibodies, not all of them by any extent, and does include things like anti-NMDA, amphotericin, as well as voltage-gated potassium channel autoantibodies, but importantly is missing some of the ones we've been hearing about in this talk. So it's not by any means a sufficient strategy. And the other hitch with these are they're expensive. These are the costs to the laboratory at our hospital, not to the patient. And as I understand the US healthcare system, the laboratory is making some money on this, so these are even higher costs to be noted. So you can't be simply sending these indiscriminately in every patient that walks into the clinic. And the reason you can't is because then your lab calls you up and makes you come and give a presentation to them to tell you why you're expending so much of their money on an annual basis. And what I've highlighted here, these are the paraneoplastic autoantibody panels that Barnes sent in 2014, which totaled over $150,000. It was their number 2 high-ranking item on their list. Number 1 if we add it all together. So this is an expensive and high component of hospital expenditures. So how do we begin to think about who to test? How do we discriminate and make that decision? So at WashU, we've been working with a group, our autoimmune encephalitis working group, to try and define that criteria. And these criteria are not meant to diagnose people with an autoimmune-mediated encephalopathy, but rather meant to help us as clinicians indicate who should be tested. I think the first question that we want to ask, going back to what is AIM, is are there two or more symptoms that relate to psychiatric or neurologic dysfunction in different brain systems? If that's a yes, we can continue to question 2. Are there objective investigations which suggest or support central nervous system inflammation, which could either come from neuroimaging findings or cerebrospinal fluid analysis? If one of those is positive, let's ensure that we've ruled out all other possible plausible diagnoses. So the patient with acute change in level of consciousness, seizures, and a florid hyperintensity in an asymmetric temporal lobe probably has herpes simplex encephalitis, should be treated for that, and we need to rule that out before we go ahead and consider alternate diagnostic entities. And this list is not meant to be exhaustive. It's meant to be sensitive but not specific, meaning that there are a plethora of cases well described in case reports and bigger series that relate other phenomena, other forms of presentation, all of which can be related to an autoimmune-mediated encephalopathy and would require and should be tested for autoantibodies. Once we've decided that we want to test the patient, what do we test? Well, in the paraneoplastic neurological syndromes, remembering that these are most often due to a tumor, whether it's detected or not, that's in the systemic system and antibodies reacting to that and presumably cross-reacting with brain components, we often have a relatively high sensitivity in testing blood, or testing serum first, Although if you're highly convinced, you have a 55-year-old smoker who has a past history of a tumor or a family history of cancer, you may want to do some reflex testing in the cerebrospinal fluid as well, looking for those autoantibodies. It's a little bit different, though, when we get into considering autoantibody-mediated encephalopathies. In these cases, at least in many of the examples, it remains very important to test the cerebrospinal fluid because you may only find the autoantibodies in the cerebrospinal fluid. And a good example of this is NMDA receptor encephalitis, where we know from excellent and well-done studies in large numbers of patients that the cerebrospinal fluid is more sensitive than serum. So whereas CSF appears to be 100% using multiple different techniques for testing these antibodies, if you rely only on serum, you may miss approximately 1 in 7 patients that has a positive autoantibody. And this doesn't seem so bad. 85.6% isn't bad for sensitivity. We'd accept that on many of our other tests. But 1 in 7 patients, if you look at it that way, can be quite costly. And as a recent example at Barnes, we had an adult patient who came in with a slightly atypical presentation, still met criteria. We went ahead to do testing for NMDA receptor autoantibodies in-house, but the team only sent serum. And when it came back negative, then they argued, well, we need to go ahead and spend $2,000 to $3,000 and do further testing for other autoantibodies. And while that testing was cooking, that test also includes spinal fluid tests for NMDA, and it came back that he, in fact, had NMDA receptor encephalitis. Thankfully, using their excellent clinical judgment, they'd already treated him and he was starting to improve and everything was okay, but it's a good example of why it's important to remember this when dealing with some of the autoantibody-mediated encephalopathies. Oh, I'm going the wrong direction. There we go. So now we enter the Romantic era. And this is an era I hope that we'll be leaving soon. And the reason that I say that is simply because we become sort of, at least in the adult world, relaxed in thinking that outcomes in pediatric AIM and adult AIM remain good following a diagnosis and treatment with immunosuppressive therapies. And I don't want to detract from that because in our studies, including the one that we've reviewed earlier, if we look at overall all the patients with encephalitis in a pediatric realm, around 70% of them attain a Liverpool outcome scale, which is essentially analogous to no deficits, that's a 5, or very mild deficits, which would be a 4. 70% of all comers attain that within 2 years of diagnosis and treatment, whereas we can see that's not necessarily the case in infectious causes, but this effect is driven by AIM, so there's reason for optimism. This is a relatively good diagnosis to make in terms of the diagnoses that we make on a regular basis in neurology. But why I say that I don't want to be lulled into a false sense of confidence, because if we continue to push and we continue to look for other abnormalities, as was done in this other study here, published in 2014, we see that while full recovery occurs in perhaps 42% of patients, if we use the right metrics and we look for other abnormalities, we see that in fact, the majority of other patients, these are followed from between 1 to 3 years, can have residual deficits which can impact their function. It may not trigger on a Liverpool outcome scale. They may be independent in getting dressed and going to the washroom, but they may still be experiencing problems like seizures, which we're pretty good at detecting, perhaps other motor phenomena such as chorea, which we're also pretty good at detecting. But what about cognition and cognitive impairment? They're perhaps not reaching the level that they would have before, or behavioral abnormalities, which our parents know so well and our patients know so well, but we're not always great at having nice measures to kind of gather those in and quantify them. We do know from these studies, though, that you're more likely to be in that better outcome category if you receive an earlier diagnosis and an earlier treatment. So as we leave the Romantic era, how do we begin to improve the outcomes in our patients? I think it's very important, first off, to increase diagnostic suspicion. That's something that we're all doing today and having this discussion, and that many of us do on an ongoing basis. And we can do that by developing criteria like this and continuing to refine it based on current literature, current experience, et cetera, to remind us to test more and more patients. We can do this by increasing the availability and affordability of diagnostic testing. So right now, these wide panels are available at a very small number of places, but our local hospital has adopted testing for some of the very specific ones that have been relatively easy to adapt. But we are still dependent on send-outs and costly send-outs to other laboratories that do these wide-reaching panels, and this is not an exhaustive list. The last thing that we can do here to really improve rates of diagnosis, I think, is to promote the clinical characterization and investigation of unknown cases. And really, what's an unknown case? Well, I think it's anything that we're still debating the ongoing etiology of. If we were to look 10 years ago, 20 years ago, the list this is just pulling a few that would be relevant to this conference, but that list would be quite extensive. However, with excellent clinical characterization, we've moved from terming things like reversible paraneoplastic encephalomyelitis associated with a benign ovarian teratoma to learning that that in fact represents anti-NMDA receptor encephalitis in a subset of patients. And this is an eight-year growth. And in that same time frame, we've seen other things disappear from that list and become incorporated within the AIM or the autoantibody-mediated encephalopathy framework, with work still to be done, I think, to bring other diseases, more understanding to other diseases and to decide where they fit and therefore what treatments are going to be best for our patients. So in thinking about that, I want to see us moving from surviving to thriving. And this is part of my goal for my research program and for the things that I want to be involved in. And I think that involves us as clinicians, as researchers, developing tools to improve the detection of deficits in follow-up. This requires standardized recommendations for treatment and age-appropriate measures for follow-up that address these domains that have been identified in previous studies. And this is going to be age-specific, which is further complicated in a pediatric realm. So evaluating behavioral abnormalities in a 3-year-old, which I have one at home, is different than the 7-year-old that I have at home. So we've got to be better at that and more efficient at that and more willing to do that. As well, we need improved detection of patients that are at the greatest risk of suffering adverse long-term consequences. Simply put, we need tools to know that when a patient comes into our hospital on day 1, they're highly likely to have deficits on day 365, so that we can maybe perhaps treat them more aggressively or treat them differently or continue to provide interventions either from pharmacotherapies or supportive interventions from psychology, psychiatry, and physiotherapy, that sort of thing. This is benefited by good retrospective studies, which we're seeing continue to be published in this domain, that confirm the natural history of specific diseases, but also prospective measures that are going to help to evaluate the usefulness of existing biomarkers, neuroimaging, other CSF measures in predicting clinical outcomes. This is a focus of our autoimmune working group at WashU. It's also projects that are going to be funded by some of the WashU resources, the McDonnell Systems Neuroscience Foundation, and my own funding through the American Brain Foundation. We also need improved disease-specific treatments, and this is a challenge. I mean, first we need to know what we're treating before we start developing treatments, but we need to rely on our governmental organizations to support this, because many of the treatments that we want to use, that we do use, are off patent, are not going to be particularly attractive. But in the pediatric realm, we do have some excellent resources through the NeuroNext network, which allows excellent development of clinical trials and implementations in multiple sites that can be expanded on. And we need increasing partnerships. We need partnerships between our parent organizations, between our perhaps even private enterprises, drug companies, and through other established groups that are working in autoimmune encephalitis that we should be bringing together to try and accomplish our mutual goals and improve our chances of success. So with that, speaking of a team, I want to thank the team that's been very helpful in bringing this together at Washington University. And I want to emphasize the collaborations that are necessary in approaching these diseases. And I think we see that reflected in the people that are in this audience today, and we want to continue to build upon that. So thank you.